Good afternoon to all. My presentation is on walking the tightrope, management of raised IOP in pediatric. You just excuse me. Please stop the time on now. So sorry. Management of raised IOP in pediatric non-infectious uveitis. The aim, it is that combination of pediatric uveitis and childhood glaucoma presents a unique challenge. It is potentially sight-threatening with paucity of long-term outcomes. So the aim was to evaluate long-term functional outcomes in pediatric non-infectious uveitis complicated by significant IOP rise. It was a retrospective observational study and included all patients less than 16 years of age with non-infective uveitis followed up over a period more than 1 year. And EMR data was accessed regarding systemic diagnosis, ocular findings, and outcomes. The diagnostic criteria we followed were that significant IOP rise is IOP more than 21 millimeters of mercury on more than 3 occasions, with or without glaucomatous disc and field changes. Steroid-induced glaucoma by IOP more than 21 or change more than 6 millimeter from baseline on more than 2 occasions after starting steroid therapy, and no other cause or evidence or with no other cause of raised IOP and evidence of reduced IOP with reduction of topical steroid use. Criteria for overall success was final IOP less than 21 millimeter mercury or decrease in IOP more than 5 millimeter with less than 2 topical medications, and failure was requiring more than 2 topical medications or above 21 millimeters of mercury. 58 eyes of 33 children were included. You can see that the mean age at presentation was 8.4 plus minus 1, and male to female distribution was nearly same. Laterality 8 unilateral, 25 bilateral. The mean time lapse between uveitis and glaucoma treatment was 8.4 plus minus 6, and mean follow-up period was about 5 years. Mean follow-up after glaucoma diagnosis was about 4.9 years. And best corrected visual acuity at presentation and at final follow-up at the point of the study was were maintaining good visual acuity at presentation as well as later on. The anatomical site of the uveitis, anterior uveitis, was the most common, followed by panuveitis, and the commonest condition was juvenile idiopathic arthritis. The most common mechanism of IOP rise was steroid-induced, and which was in 38 eyes, angle closure synechial in 4 eyes, and uveitic open-angle glaucoma in 16 eyes. The mean IOP at the time of presentation of the patient was 17.83, and mean IOP at diagnosis was 28.68, which was significantly reduced during the follow-up period. The time lapse of uveitis diagnosis to development of IOP rise, the mean duration was 8.38 plus minus 6.2 months. In the steroid-induced subset also, the mean time was little less, but it was not statistically significantly different from the other. Management of the uveitis, all 58 eyes were on topical steroids in the beginning, while 32 needed oral steroids. On final follow-up, patient distribution on basis of the immunomodulatory therapy where only 6 patients were on steroids, while most of them were on other immunosuppressive drugs, methotrexate plus MMF, methotrexate, MMF, and adalimumab, and also methotrexate plus adalimumab in 2 patients. IOP control of 58 eyes, 46 eyes were successfully managed by medical management, and at final follow-up, 33 eyes achieved IOP control without any topical AGM. 32 of the above 33 eyes belong to the steroid-induced group. So they all reduced with just topical medication and reduction and stoppage of the steroids. And surgical management was needed in 12 eyes of 9 patients. 5 eyes underwent glaucoma filtering surgery with MMC. 5 eyes combined glaucoma filtering surgery and cataract, and both eyes of 1 patient underwent laser cyclophotocoagulation. In children who underwent surgical intervention, the number of AGMs reduced from 2.34 to 1.26 at final follow-up, and surgical procedures other than the glaucoma filtering was 1 eye underwent cataract surgery, and both eyes of the same patient underwent intravitreal dexamethasone implant. In 30 patients, we found favorable outcome, and treatment failure by our definition was seen in 6 eyes of 3 patients. Other ocular complications seen were cataract, band-shaped keratopathy, posterior synechia, macular edema, disc edema, and cyclitic membrane. So the key to balance good IOP control and inflammation control is the key here, and that is by walking the tightrope. And one thing that we found that in our study, 3 eyes developed IOP rise even after 5 years after initial diagnosis. So long-term follow-up later on also, these patients can develop raised IOP. Timely initiation and maintenance therapy, most of them were able to maintain a good visual acuity. In our number of patients who required surgical intervention were less compared to other studies, and the reason is the immunomodulatory therapy was initiated earlier itself, that reduced both steroid-induced glaucoma and inflammatory glaucoma. In other studies, when we compare, we have very similar incidence of JIA, 36.4%, and eyes that underwent glaucoma surgery, however, is less compared to all the other studies. So my take-home message is that timely diagnosis of uveitis, aggressive control with immunomodulation can help reduce the incidence of steroid-induced glaucoma and generally IOP rise in these children and give good results. Thank you.